Hi, bienvenue, bonjour. Yeah, welcome to today's weekly research conference. And this is going to be another exciting installation for from a very, very accomplished researcher. And just some of the logistics, I'm sure folks are very familiar already. And so please pose your questions using the Q&A feature on the bottom of your screen. You can do this throughout the presentation, and we'll endeavor to answer them in turn. And if you would like to pose the questions in person, that's also very welcome. Please use the hands up feature and we'll invite you to join in the panel. And then you'll be able to pose the question directly and have the question Q&A live. And also please use the chat feature if you have any technical difficulties. And Kelsey or Allison will make sure that you can join us successfully. And today, we're absolutely delighted to have Professor Thais Coutinho to give us a really exciting update on vascular health. And she's one of our superwomen role models on our faculty. Not only she's a clinician scientist at the Heart Institute doing cutting edge research on vascular health and aortic diseases, she's also chief of the Division of Cardiac Prevention and Rehabilitation, chair of the Canadian Women's Heart Health Center, and also associate professor in the Department of Medicine at the University of Ottawa. She received her medical degree from Universidade Federal de Rio de Janeiro in Brazil, and then completed her residency and fellowship in internal medicine, cardiology, vascular medicine, advanced echo, and research at Mayo Clinic in Rochester. And Dr. Les Cooper, who many of you know, who's the head of cardiovascular medicine at Mayo and a very good personal friend, made the absolute error of mentioning once that the Thais is Mayo's top trainee and that her husband's Canadian. This activated the whole team recruitment effort on our part, and that we succeeded in getting Thais to the Ottawa Heart, and we're counting our blessing every day. Les Cooper told me regularly that one of his biggest career mistakes was to let Thais come to Canada and not being able to keep her at Mayo. Well, that's our benefit, our fortune. Dr. Coutinho's research focused on arterial health, special emphasis on arterial stiffness, and his role on the pathogenesis and sex differences in cardiovascular diseases. She holds multiple research grants to support this, including Early Research Leadership Grant and the grant in aid from the Heart and Stroke Foundation of Canada, a project grant from the CIHR, and a coveted Clinician Scientist Award from the Heart and Stroke Foundation of Ontario. And for her work, she has received many recognitions, including the American Heart Association's Young Investigator Award, the Mayo Clinic's Summer Skill Research Award, and Outstanding Research Achievement Award, the Canadian Cardiovascular Society's Young Investigator Award, our Ottawa Heart Institute's Global Impact Award, and most recently last year as Women as One Global Research Award. And she's also widely recognized for effort in education and knowledge translation, including co-chairing the first three major Canadian Women's Heart Health Summit, and the most recent one in 2021. And these are the largest conferences dedicated exclusively to the cardiovascular health of women in the world. And she also launched and chaired the Canadian Women's Heart Health Alliance, a national network focused on bridging the knowledge and practice gaps pertaining to women's cardiovascular health issues. I'm fortunate to actually learn Twitter from Thais, and that we are I can claim the fact that we are Twitter buddies, but she has 10 times the follower as I do. And they're all big fans of Thais. It really shows the power of Thais as a true scientific influencer. So it's really a privilege for us today to have Dr. Coutinho present an update entitled "The Aorta is Not Just a Pipe, Addressing Aortic Function to Improve Risk Assessment in Patients with Thoracic Aortic Aneurysms." The floor is yours, Thais. Thank you so much.
Thank you very much, Peter, for your introduction. And you did send me down memory lane with some of your comments there. Very happy to be here. Thanks to you and the research services team for the invitation today to update the team on my work. And welcome to all of you here in attendance today. So today we're going to focus on the aorta. And I think one of the biggest mistakes that we make as clinicians and as scientists is to look at the aorta and see only a tube. The moment we start to understand that the aorta is a functional organ and whose functions are essential for the maintenance of the health and efficiency of the entire cardiovascular system, the moment we move beyond just a pipe and understand the true functions of the aorta, we can really start to understand how the aorta itself can contribute to a number of cardiovascular diseases. We don't have the time today to talk about a number of cardiovascular diseases, so we're going to focus on thoracic aortic aneurysms. I have no disclosures. Now, imagine a disease that is clinically silent, but when it does manifest itself, this very first clinical manifestation is catastrophic. 22% of patients that manifest this disease die at home before ever reaching medical treatment. And among those that reach the hospital alive, mortality is estimated to be 1% per hour, and 34% of them actually die in hospital. This disease is thoracic aortic aneurysms, a disease that is clinically silent, fairly slow in progression, but very, very virulent. This is what I have to show you in terms of epidemiology of thoracic aortic aneurysms and dissections. So as you can see here in the recent epidemiologic study, it is estimated that about 8 per 100,000 adults have a thoracic aortic aneurysm, and about 5 per 100,000 adults will eventually suffer a acute aortic syndrome. About 2/3 of them will be a type B aortic dissection, and another, or a type B acute aortic syndrome, and another third will be a type A. Now, when you look at these numbers, just know that they are undoubtedly underestimated. We discover most aneurysms incidentally. It is discovered in 1% of all chest imaging studies. And we know that aortic dissection is one of the greater masqueraders in medicine. There are many people that die suddenly and never have an autopsy, and that automatically are labeled as having died of a heart attack or stroke, when in fact, many of those deaths were actually aortic dissections. So when you look at these numbers, you just know that the true numbers for aortic aneurysm and dissections are going to be even higher than this. This is also data actually from Canada, specifically from Ontario, looking at the temporal trends for 3-year mortality after aneurysm, after dissection on the left, or just having a non-dissected aneurysm on the right. And the reason I wanted to show these graphics is, of course, we can see some slight improvements in the 3-year mortality trends for both dissections and undissected aneurysms. But what I really wanted, the message that I really wanted to convey with this slide here is that if you just compare the 3-year mortality for an undissected thoracic aortic aneurysm, just having an aneurysm in the chest, is about 25% in 3 years, and actually higher for women. It's about 35% or about 30% in 3 years for women. And if we compare with Canadian data for the 5-year mortality for all cancers combined, it's 37%. So what is the message here? The message here is that being diagnosed, even with an undissected thoracic aortic aneurysm, carries a very similar prognosis to being diagnosed with a cancer. Yet, funding for cancer research is very abundant. There's a lot of talk about awareness and a lot of work for innovation in the cancer field, but unfortunately the same cannot be said for thoracic aortic aneurysm. So it's still a relatively orphan disease that we still need to invest a lot more research and clinical innovation on to be able to reverse these trends. Still in the epidemiology of thoracic aortic aneurysm, I also wanted to touch upon some of the sex differences in this disease. I have an entire talk on this topic alone, but for the purpose of this brief conversation today, it suffices to say that there are significant sex differences in thoracic aortic disease. Thoracic aortic aneurysms are a lot more common in men as compared to women. However, for the few women that do go on to develop a TAA, TAA being short for thoracic aortic aneurysm, they have much worse prognosis. A woman with a TAA has 3 times higher risk of dissection compared to men, and about 40% higher risk of death as compared to men. And the true reasons for these sex differences are still incompletely understood and a very fertile ground for further investigation. Now let's talk a little bit about aortic pathology, and starting here with what does a normal aorta look like? And believe me, this will become relevant later on as we start to talk about some of the aspects of my research. But let's take a look at a normal histology slice from a normal healthy aorta. On the left, you can see the 3 layers like every artery, and you can see that in the aorta, the media is certainly the predominant layer. And on the right, when you have a special stain for elastin, you can see just how abundant elastin is across the media of the aorta. You see this very abundant arrays of elastin fibers that are very nicely organized, and they compose the great majority of the media. So for this reason, the aorta is really a very elastic artery, and it is our elastic reservoir for the body. So remember this image here, and remember how nicely these elastic fibers are laid out in the media and very nicely organized and undisrupted. Now let's look to see what happens in the body of a thoracic aortic aneurysm. So if you take a piece of a thoracic aortic aneurysm and look under the microscope, and regardless of the etiology, you're going to see a combination of these 4 pathological abnormalities here. And in some cases, one will be predominant over the others, but usually you see these 4 things being present in the body of a thoracic aortic aneurysm. One, here on the top left, we have elastic fiber fragmentation and loss. Here, the elastic fibers are stained in this dark blue. And as you can see, they're no longer undisrupted and nicely organized. They're all broken. And you see several areas without elastin whatsoever. The other thing that happens in the body of an aneurysm is medial fibrosis with deposition of collagen. In this trichrome stain here on the bottom left, you see these areas that are stained with blue. This is collagen. This is fibrosis that has now permeated through the body of what used to be a very elastic artery. On the top right, we have a very disorganized pattern of the smooth muscle cells and even hypertrophy. You can see that this is completely chaotic. And lastly, on the bottom left, in the bottom right, you have some mucoid extracellular matrix accumulation. So that is the histopathology of a thoracic aortic aneurysm. Also keep these abnormalities in mind because they're going to, I'm going to draw some parallels to aortic aging in a moment. Now let's talk about the clinical management of non-dissected thoracic aortic aneurysms. How do we manage these people in the clinic? We look at their aneurysm size, and the reason for that comes from previous epidemiologic studies, which is one of them is highlighted here, to show that there is a significant increase in the risk of aortic complications, such as rupture, dissection, or death, once the aorta reaches a certain size. And when you look at a curve that plots size with risk of complications, the shoulder of that curve occurs at around 6 centimeters. So when an aorta, I'm talking about aortic root and ascending aorta here. So when the aortic root and ascending aorta reach 6 centimeters, there is a significant increase in the risk of major complications, aortic rupture, dissection, or death. So for that reason, all the guidelines throughout the world have said, okay, if the risk increases that much further at 6 centimeters, let's start to promote surgical repair prophylactically at about 5.5 centimeters. So before they reach that very critical size of 6 centimeters. So this is what guidelines have recommended. We recently wrote a brief teaching paper for the CJC that we summarized some of the clinical guideline recommendations. But here on the left, these are going to be the majority of the patients that we see in clinic. There are patients that have sporadic aortic aneurysms, And for those patients who compose the majority of our clinical practice, we usually recommend surgery when the root or the ascending reach 5.5 centimeters, or the arch reaches 6 centimeters. For patients that have heritable forms of aortopathy, such as many of the bicuspid aortic valve patients, Marfan's, the Loeys-Dietz, Turner's, vascular Ehlers-Danlos, or the familial thoracic aortic aneurysm and dissections, and many other syndromic aortopathies, there will be smaller cutoffs that are proportional to the risk of the heritable condition. But again, the majority of our patients are going to find themselves in this 5.5 centimeter recommendation, or between a 5 and 5.5 centimeter recommendation. So what do? So we watch these patients in clinic until their aorta reaches a certain size, usually above 5 or 5.5, and then we recommend prophylactic surgery at that time. Now, if I go back to the same slide that I had earlier, where we talked about the risk of rupture, dissection, or death based on size, if you just then change your focus to these two graphics here. So these are patients that are they actually had one of these very serious complications, but their aneurysms were smaller than 5 centimeters. So the point that I'm making here is that the size of the aneurysm is a good marker of risk for complications and death, but it's not perfect, because there is still going to be a not low proportion of patients with aneurysms smaller than 5 centimeters that are still going to suffer one of these deadly complications. So this can be anywhere between 5 and 8% of our patients, which is actually a fairly high proportion. So message here is aortic size matters, aortic size is important, but it's not perfect. And I would argue that for disease as virulent and as deadly as thoracic aortic aneurysms, we should strive to be as perfect as possible in our risk stratification. And this is why I personally think that we have to move beyond just looking at size and start to think of other parameters that we can use to monitor and risk stratify and treat these patients. So these are the problems that the clinicians and the patients face. For the ones of you in the audience, you know very well what I'm talking about here. We know that thoracic aortic aneurysm is a clinically silent but very deadly, potentially deadly disease. We only use the aortic size as a parameter to aid in our clinical decision-making, which is an imperfect marker of risk. Good, but imperfect. We have no risk stratification algorithms for patients with TAA. We don't have any insights of timing of image surveillance. In other words, who do we have to image every year, and who can we just relax and spend a few years without having to check their aortic size? We don't have any sex-based data regarding clinical management of TAA, and we don't have any non-surgical therapies to contain disease activity outside of Marfan. And I say this because Marfan is the only form of aortic disease that has been subjected to randomized clinical trials. And we know that we can use beta blockers or ARBs to decrease the rate of aneurysm expansion in Marfan, but we haven't had these clinical trials outside of the Marfan world. And Marfan is just about 5% of our clinical practice. So this sums up as a management of thoracic aortic aneurysm is simply watchful waiting until surgical criteria are met, and then surgery to repair or replace this disease segment of aorta, which as a clinician, especially as a cardiologist, I've always felt very uneasy about it, about this process of just having to watch this disease develop in front of me and not being able to do anything that I know about to really perhaps avoid surgery, contain disease activity. And these are some of the things that I hope to be able to do and answer with my research over the course of my career. So when I moved here in 2014, and Peter gave me some great memories today of the recruitment process. So when I moved here, I was determined to start a research program to evaluate markers that can predict aneurysm expansion in men and women with thoracic aortic disease. With my overall career goals over the next 20 plus years that I hope to have ahead of me, to identify methods to improve risk stratification of TAA, develop a risk score that is going to help clinicians and identify disease activity for their patients, determine optimal imaging interval, who needs yearly imaging, who does not, and hopefully identify therapeutic targets that may help us curb disease activity and obviate the need for surgery. That would be like a dream of mine that I hope to accomplish in the next couple of decades, I think. Now, let's talk about some of the focus of my research. And what I'm showing you here in this animation is a vision of the cardiovascular system the way that we learn in school. We learn that the cardiovascular system has one functional organ, which is the beating heart, and then the blood vessels, and I'm just going to focus on the arteries here. So the arteries are passive, simple conduits of blood that simply exist to connect the beating heart to the end organs. And while this conduit function of the aorta is absolutely correct, the aorta has additional functions beyond simply being a conduit that really play a significant role in the maintenance of the efficiency of the cardiovascular system. In addition to being a conduit, the aorta, and in fact, all the arteries have a significant role to maintain continuous blood flow forward throughout the cardiac cycle. And importantly, the aorta, for being so elastic, is our main pressure buffer. And that's what I focus on in my research, is in the pressure buffering function of the aorta. The pressure buffering function of the aorta is well exemplified here in this graphic at the bottom. Here on the y-axis, we have pressure, and then we have the different layers of the cardiovascular system from left ventricle all the way to the capillaries. As you can see, pressure pulsatility in the left ventricle is enormous. The pressure in the left ventricle is 120/5 in a normal person, even higher in some individuals. So if this pressure pulsatility was directly transmitted to the end organs have very fragile capillaries and arterioles that would easily burn out and be destroyed, and we wouldn't live as long if we were to deliver all of that pressure pulsatility all the way to the end organs. But you can see here what happens at the level of the aorta. The aorta, for being so elastic, is able to buffer a great chunk of that pressure pulsatility and help contain pulsatility, which then continues forward as it travels along the arterial tree. So as you can see, the pressure goes from 120/5 to 120/80, for example. And this is a really good illustration of the pressure buffering function of the aorta. And for the aorta to exert this pressure buffering function, it has to be very elastic. The moment it loses its elasticity, is going to lose its pressure buffering function, at least partially, and allow greater pulsatility to not only exist, but also be transmitted down the arterial tree. So I just told you how the aorta is very elastic. So let's then change the focus to the concept of arterial stiffness. The stiffness is something that happens with our aortas in all of us as we age, because the aorta is indeed an elastic structure. So its fibers over time are going to suffer the same process of elastic fatigue that any other elastic material suffers. Unfortunately for us, we do not have the opportunity to lay more elastin in our vessels. All the elastin that we're gonna have for a lifetime, we're born with. And then we have to deal with that amount of elastin for the rest of our lives. So what happens is, over our lifetime, the left ventricle will beat, billions and billions of times. I don't even know how many times, trillions. So that means that the aorta is going to have to stretch and recoil that many times. And that constant stretch and recoil causes fatigue of the elastic fibers and eventually breakdown of these elastic fibers in the wall. And I know it's fairly cliche, but I always have my hair elastic handy every time I give these talks, because it's really a great example. This elastic I have here is actually in pretty good shape. Sometimes when I've used it a lot, you can actually see the little chunks of broken elastic poking through, because it literally breaks off after I've stretched it so many times. And the same happens in the wall of the aorta. There's a breakdown of the elastic fibers, and that causes a vessel remodeling or vessel dilation. Again, my hair elastic used to be smaller when I first bought it, and now have just stretched it so many times, it is a little bit bigger, and it will never go back to that original size. So this vessel remodeling and vessel dilation, if you remember Laplace's law, puts further stress on the arterial wall, and then the body tries to compensate. They try to fix, but they cannot fix it with elastin, because we don't have the capability of putting elastin back into the media. So there's some medial hypertrophy, and then the body starts to deposit collagen to fix the problem. But the problem here is that collagen, differently than elastin, is a tensile fiber. So it actually further stiffens the aortic wall, which in turn exacerbates the pulsatile stress, and this continues. So this cycle is part of aging for all of us humans. And all of us will go through it. So this is the quintessential aspect of arterial aging. And the bad news is that, yes, we're all gonna go through it, but the good news for all of you in the audience is that we can decelerate this process by leading healthy lifestyles and specifically engaging in aerobic exercise through our lives. That's kind of my parenthesis comment to all of you listening to this. We can decelerate the arterial aging and arterial stiffness with healthy lifestyle measures. But this is what arterial stiffness does. And then what happens to the aortic function, the pressure buffer function of the aorta as we age? Well, the aorta stiffens, as we talked about. Resulting from that, the aortic characteristic impedance goes up. The aortic impedance is the pressure flow relationship in the proximal aorta. So if aortic impedance is higher, you will have, for the same flow of blood that the heart generates, the same flow of blood, you're gonna have a greater variation in pressure. So then your pulsatility increases and your aortic compliance decreases. And hemodynamically, what does that translate into? It translates into the aorta's decreased ability to buffer pulsatile pressure. Therefore, the amplitude of the forward pressure wave that is generated by the interaction of the ventricle with the aorta is going to increase. That's what we call PF, which is the pressure forward. The amplitude of the reflected pressure waves increase as well. We call it PB. It's the P or pressure back as the reflected pressure wave. Our central systolic and central pulse pressures are going to increase. So these are the pressures at the level of the aorta. So these are some of the hemodynamic consequences of arterial aging and arterial stiffness. And here is a nice illustration of the hemodynamic end game of aortic aging. So as we age, and this is going to be more or less exacerbated based on the person, as we age, the amplitude, especially of the incident pressure wave, starts to increase because of the decrease in the pressure buffering the function of the aorta. And the overall end game, as you can see in the green here, is that a significant widening of pulse pressure as we age. For the clinicians in the room, this is the isolated systolic hypertension that you often see in the elderly. Now, we talked about arterial aging, but this talk is about thoracic aortic aneurysm. So what are the parallels here? And in this figure that I very proudly created with our colleagues in pathology for a book chapter that is just being published right now, I think it really helps us understand the true similarities between aortic aging and aortic aneurysm. So if you focus on the left panel, here we have a young person that died from non-cardiac causes at the age of 16. So this is a young, elastic, and healthy aorta. The aorta is rich in very abundant and organized elastic fibers, which has stained here in the dark blue. There is very little collagen. The tiny little specks of light blue or light purple in the middle panel here, it's a little bit of collagen here and there. And as you can see, the vascular smooth muscle layers are thin, organized, nicely oriented. This is a nice, wonderful aortic architecture. Now let's look at an aged aorta, a 72-year-old man. As you can see, the elastic fibers also stained here in the dark blue are no longer intact and organized. Some of them are broken. You see some areas that are light purple here, which are areas that you have loss of elastic fibers whatsoever. On the middle panel, you have more of those areas of light blue or light purple, which means there's even more collagen that has been deposited into this wall. And you can see the vascular smooth muscle is completely disorganized and hypertrophied, very different than what is seen here. That's an aged aorta in a person without an aortic aneurysm. Now, just compared here on the right side of the panel, this is a specimen of an aortic aneurysm for a 61-year-old man, therefore over a decade younger than this man here. But as you can see, all of these abnormalities of aortic aging are magnified in the body of a thoracic aortic aneurysm. The elastic fibers are completely disrupted here. You have several areas without elastic fibers whatsoever, completely loss of the usual architecture. The asterisk shows significant deposits of collagen throughout this wall and further disorganization and hypertrophy of the vascular smooth muscle. So the way that we think about this is that a thoracic aortic aneurysm actually represents a focal accelerated and exacerbated aging of that segment of the aortic wall. So think about a thoracic aortic aneurysm as a focal aortic aging on steroids. So if you already understand now the importance of maintaining the regular aortic media architecture to maintain the function of the aorta, and I just told you that thoracic aortic aneurysms have even greater disruptions in the architecture of the aorta, we start to hypothesize that maybe we can see changes in the function of the aorta as well, which truly has been the basis of my research. So when I started here, I had a central hypothesis that measures of aortic health, aortic aging, aortic stiffness, and the measures of pulsatile arterial load will be independently associated with thoracic aortic aneurysm expansion. So how do we assess then the aortic hemodynamics? So here in Ottawa, we choose, there are many ways you can do this, but we chose to do it non-invasively by combining pressure data from arterial tonometry with flow and volume data from echocardiography. So if you have pressure, flow, and volume, you can actually mathematically calculate a number of important hemodynamic parameters, and in a very validated and a high fidelity way as well. So this is how we do it here in a lab. And here's just a snapshot of our non-invasive hemodynamic lab on the first floor. If I look a little bit around in this picture, my daughter Sophia was born 2 days after this picture was taken, but the purpose was here to show you just the high fidelity waveforms that we can obtain non-invasively. You would think that we have a catheter inside the artery. And here's a demonstration of our pressure flow analysis where we have pressure on the top, flow on the bottom, very nicely matched in a healthy aorta. So we do all of these fun things in our lab on the first floor. So I'll divide some of our research results into cross-sectional and retrospective first, and then I'll move on to our prospective studies. So starting with our cross-sectional and retrospective studies, the very first study that we ever did when we started was just to simply look at sex differences in aneurysm growth, because I showed you earlier that women with thoracic aortopathy are much more likely to dissect and to die from the disease. So we wanted to see, is the aorta growing differently? Do women with TAA have greater disease activity? And what we found is that, yes, they do. So on the left, we have just all patients, and you can see that the growth rate of the thoracic aortic aneurysm was twice as fast in women as compared to men. We found the exact same thing if we index the aneurysm to the body size. But when we divided the sample here on the right into those that had degenerative thoracic aortic aneurysms, these are going to be older and predominantly hypertensive individuals, AKA aortic aging. And then we also divided them into, so the degenerative aneurysms, but also heritable aneurysms, so your Marfan's, BAVs, Loeys-Dietz, etc. You can see that the sex difference in aneurysm growth is really only noticeable among those that have degenerative forms of aneurysm disease. Those that have heritable forms don't experience a difference in aneurysm growth. And this was confirmed in multivariable models. So what we learned from this very initial study is that there's something about women, especially women with degenerative thoracic aortic aneurysm, so older hypertensive women, that predisposes the aorta to be much more prone to dilation over time. So the disease activity seems to be more aggressive in that subset of the patients. To further explore this aspect of what is about the women with degenerative thoracic disease that may be so interesting from a disease activity perspective, most recently, Emily Parkin took this subset of patients from our sample that had degenerative aneurysms and literally compared the aortic and arterial hemodynamics between the men and the women. And she just presented this at the Organization for the Study of Sex Differences conference in California last week. And what we showed is that when you look at the subset of patients with degenerative aortopathy, women have worse arterial health. They have greater markers of pulsatile arterial load. So shown here in an example, the women with DTAA had greater aortic characteristic impedance, they had lower arterial compliance, and they had greater amplitudes of the forward and the reflected pressure waves, reflected and forward pressure waves as compared to men with degenerative aortopathy. So maybe because they have greater disruptions in aortic function, they could be more prone to faster growth over time, or maybe that's a signal that they have a greater alterations in the body of the aorta. So we are finding here that women with DTAA, the genitive TAA, have greater abnormalities in pulsatile arterial load and arterial function as compared to men. Still trying to understand the sex differences in thoracic aortopathy, we did a retrospective study at first that looked at the associations of aortic stiffness, which is measured here by its gold standard measure, the carotid femoral pulse velocity, with the previous growth of the aneurysm, the previous growth rate. And what we found is that while the stiffer the aorta, the faster the growth rate of the aneurysm up to that point, it was very interesting that there was a significant interaction between sex and aortic stiffness in the prediction of aneurysm growth. So that motivated us to then divide the sample based on sex. And we found that the associations of aortic stiffness with aneurysm growth was truly only present in women. And this was, again, also maintained in multivariable linear regression. So that once again, we're getting this flavor that there's something about arterial function in women that is more contributory to their overall disease activity. Again, continuing on our efforts to understand sex differences in TAA, in this cross-sectional study, we correlated several markers of aortic stiffness and pulsatile arterial load with the size of the aneurysm. And in blue, we have men, and in red, we have women. And what we found, again, subsequently confirmed in multivariable models, is that in women only, shown in red, the stiffer the aorta, the lower the compliance of the aorta, the greater the blood pressure in the aorta, and the greater the amount of wave reflections in the aorta, then the bigger the aneurysm size. And these associations were not present in men. So what we're learning, I think, as we start to put the pieces of the puzzle together, is that disease activity in men seems to be somewhat unrelated to hemodynamics, but in women, they seem to be very related to hemodynamics. It contributes to size, it contributes to growth, and it may be that women with thoracic aortic disease, particularly degenerative disease, may have a lot more structural and functional alterations in the body of the aorta. Now, changing gears a little bit, another retrospective study that we did early on was to look to see whether pulsatile hemodynamics also had a role in patients that had bicuspid aortopathy. Because, you know, thinking about the degenerative aortopathy is easy. These are older and hypertensive individuals. But bicuspid aortopathy, the patients tend to be a little bit younger, half of them, but not all, have hypertension. So is this still a significant predictor? And what we found here, I highlighted with the red boxes, the findings that were statistically significant. We found that yes, even in patients with bicuspid aortopathy, which is the second most common form of aortopathy that we see in clinic, several of the measures of aortic function was still correlated independently with faster aneurysm growth. So namely, greater central systolic blood pressure, the greater aortic characteristic impedance, the lower the proximal aortic compliance, and the lower the total arterial compliance, and the greater the forward pressure wave amplitude, and the lower the reflection coefficient. All of these measures were associated independently with faster aneurysm growth in BAV. So this does not seem to be specific to our patients with degenerative forms of aortopathy. Now we move on to our prospective studies. And this was really our piece de resistance, is really our proof of concept study that we were very proud to publish with Kevin Boxar and all of our collaborators here at the Hearth Institute in hypertension a couple of years ago. So we took our sample at that time, which was 106 patients, followed by about 3 years on average prospectively. So in this instance, we measure and characterize the hemodynamics at baseline, and then we watch them prospectively to see what happens to the aneurysm. The average size of the aneurysm in this cohort is 4.6 centimeters, I wanted to point out, because that's very much reflective of what we see in our clinical practices. So what we see here, these are the summary results of our multivariable linear regression models using aneurysm growth rate as a dependent variable. And as you can see here, every single one of the measures of aortic stiffness and pulsatile arterial load were independently associated with faster future aneurysm expansion. The central systolic and pulse pressure, the higher the aortic stiffness, the higher the aortic impedance, the lower the proximal and total arterial compliances, and the higher the amplitudes of the forward and reflected pressure waves. All of those measures of stiffness and pulsatile load, all independently associated with future growth. And just for proof of concept purposes, we threw in another measure, the hemodynamic measure here, which is the systemic vascular resistance, which is a measure of hemodynamics that has absolutely nothing to do with the aorta. The systemic vascular resistance is determined by the resistance of the muscular arteries and arterioles. So the aorta has no role here. And when you look at that measure, the systemic vascular resistance, it had no relationship to aneurysm growth. So all of the measures that depend on the aorta were related to aneurysm growth. The measure that does not depend on the aorta does not. So here's a great example of this data. So here we have two women. Imagine clinicians in the room here. Imagine you're seeing these two women in your clinic today. They have the same age. They're both hypertensive. They're both formerly smokers. They have similar body sizes, and they have similar aneurysm sizes between 5 and 5.5 centimeters. You're seeing these two women in clinic, and you do not know what's going to happen to them, right? They look the same, so you're going to treat them the same way. Well, when we characterized their hemodynamics, they were very different. So the woman on the top had really stiff aorta and really terrible arterial hemodynamics that were 2 to 3 times worse than the woman on the bottom. The woman on the bottom had arterial stiffness and hemodynamic load measures that were much more compatible with her age. So directly resulting from this perhaps, the woman on the top experienced an aneurysm growth rate over time that was 3 times faster than the woman on the bottom. So again, in clinic, if you just look at them based on clinically available variables, you cannot discern who is who. But once you understand the hemodynamics, you see that this woman has a hot aorta. This woman has a cold aorta. That's how I think about it. And maybe this could be helpful in the future in risk stratifying these patients. Now, we know that aortic size is helpful. We now have proved the concept that aortic function is helpful too. So that led us to the idea of how about combining size and function? And this paper that is presently under review, hopefully soon to be out. But we did 2 aspects in terms of evaluation of this paper. The first aspect is what's shown here, where we calculated standardized beta coefficients for the multivariable linear regression models, again, using aneurysm growth rate as the dependent variable. And by having the standardized betas, we can actually compare the strengths of the association between each of these measures with aneurysm growth. So if you look at aneurysm size, which is our current standard of care, the standardized beta for an evaluation of future aneurysm growth was 0.18. As you can see here, nearly all of the measures of aortic stiffness and pulsatile arterial load had stronger associations with future aneurysm growth as compared to the standard of care, which is size. So that was one message from this paper, is that these measures seem to be even better than what we're using in clinic to understand disease activity. But then we combined them. So we wanted to see, okay, what happens if we combine size with each of these hemodynamic measures in the assessment of aneurysm growth? And what we saw is that these key combinations here, these 4 key combinations, if you combine size with aortic stiffness, size with the inverse of proximal arterial compliance and total arterial compliance, and size with the central systolic blood pressure, you actually improve the strength of the association compared to either measures of function or measures of size alone. So it got us a little bit further. I spoke earlier about our need to be as perfect and precise as possible. So combining size with function seems to lead us a little bit closer to that precision that we're really looking for in treating these patients. The other concept that we wanted to tackle with our data is the concept of central hypertension. It is no secret to anyone that hypertension is the #1 population attributable risk factor for aortic dissection in the world. The majority of patients, up to 2/3 of patients with thoracic aortopathy, have hypertension. It's a big deal. But to me, what do we care about the blood pressure in the arm? What I really care about is what is the blood pressure that the aorta is having to deal with? What is the central blood pressure? And that's the concept of this study. So we took our sample and we divided them into those that had or did not have a previous clinical diagnosis of hypertension. It was about half and a half. As you can see, the patients that had a previous diagnosis of hypertension had larger aneurysm sizes as compared to those that did not have a clinical diagnosis of hypertension. But then we took these people that had no hypertension anywhere in their charts. They never got told they had hypertension. They were not taking antihypertensives. And then we found that about 22% of them had central hypertension, and 15% of them had central hypertension, which is defined as a central systolic blood pressure of 130 or higher, despite a completely normal brachial blood pressure. And for those patients that had this occult central hypertension, their aneurysm sizes was much more comparable to the frankly hypertensive patients. When we look at our multivariable regression models to evaluate future aneurysm growth, we found that among patients that had a diagnosis of hypertension, the higher their central systolic and pulse pressure, the faster the aneurysm grew over time. But this relationship did not exist independently with brachial pulse pressure or brachial blood pressure. And among those with no previous diagnosis of hypertension, higher central systolic and pulse pressures were correlated independently with both a larger aneurysm size and with a faster growth of the aneurysm over time, while these associations were not noted independently with the brachial blood pressure. So here's a thought that it may be we should be focusing even more on central hemodynamics and central blood pressure in our patients with thoracic aortopathy. And the whole talk I've been making parallels and drawing parallels between arterial age and aortic aneurysms. The reality is that there is a fun thing that we can do with our data, which is actually calculate arterial age. I'm 40 years old, but when I was, I think 38 or 37, the last time I calculated my arterial age, and it was in the mid-20s. So I was very, very happy about that. We can actually, once we know people's pressure as well as their carotid femoral pulse rate velocity, we can actually back calculate their arterial age based on validated equations as shown here. So we wanted to calculate the arterial age of our TAA patients and see how did that compare to chronological age in terms of evaluating their disease activity. So as we can see, the patients actually on average throughout the group had a younger arterial age as compared to their chronological age. However, about a third of patients had what we call early vascular aging, which is an arterial age older than their chronological age. So it's prevalent, a third of our patients. When we did our multivariable linear regression models to predict growth of the aneurysm over time prospectively, we found that the chronological age was not independently associated with growth, but the arterial age was. And we did multivariable logistic regression models to predict accelerated growth, which was defined here as growth above the median in the sample. And again, for each 5-year increase in arterial age, there was about 12% increase in the odds of experiencing accelerated aneurysm growth over time. So the message here is that we don't care how old our patients are, we care how old their arteries are. And that seems to be more relevant also for understanding disease activity. Now, we've proven this concept, I think. So now we are in a stage of our research plan that we're trying to make things simpler, because I really, really want to make this a clinically useful and practical tool. And I cannot imagine centers everywhere doing these super comprehensive arterial hemodynamics that I do in my lab. So how can we make them simpler for implementation? So we have now taken a couple of steps to simplify things. One, we wanted to know if we had to repeat the hemodynamics on a yearly basis. And the answer is no. We can, in this particular study, 86 of our participants had not only their baseline hemodynamic study, but also a follow-up study 1 year later. And what we found is that, again, in our multivariable regression models to predict aneurysm expansion, once we knew the baseline hemodynamics, the incremental change in hemodynamics after 1 year did not make a difference. They were not associated independently with aneurysm growth. So I took that as really good news. So that means that we don't have to repeat this every year. Maybe one day we test it every 5 years and such. But right now I would say we can just do it once and we get a good snapshot of disease activity and we don't have to be repeating this. So I think this is great news for clinical implementation. The other step to make things practical that I wanted to highlight is the role of estimated pulse wave velocity. So again, the carotid femoral pulse wave velocity measured with arterial tonometry is the gold standard measure of aortic stiffness, is what we do here, and many centers do around the world. But not everybody has a tonometer. We don't get paid to do a tonometry. Not everybody has a sonographer or a student or a technician that can do it. So can we estimate it? And again, thankfully for us, there have been validated equations that we can use that can estimate aortic pulse wave velocity based on the patient's age and mean arterial pressure. These validated equations are shown here. So we then undertook this exercise of comparing estimated and measured aortic pulse wave velocity. So what we found is, first of all, estimation of pulse wave velocity does pretty well. As you can see here, it actually very closely approximated the actual measured carotid femoral pulse wave velocity with a correlation coefficient of 0.6. And then we developed these multivariable linear regression models for aneurysm growth. And all the covariates in the model were the covariates that we use when we are assessing patients in our clinic: age, sex, body surface area, blood pressure, size of the aneurysm, follow-up time, all of these things that we consider when we see our patients. And then to this base model, we added either the measured aortic stiffness or the estimated aortic stiffness. And the reality is, not only is estimated aortic stiffness also independently associated with future aneurysm growth, but addition of either measured or estimated pulse wave velocity to this base model increase the R-square of the model from 0.39 to 0.44, so very similar. So what we're learning here is that, okay, if you have the ability to measure, but if you don't have the ability to measure, maybe estimate, and that may already bring us a little bit closer to understanding disease activity as compared to our clinical variables alone. So in summary, what have we learned so far? We learned that aortic function matters in thoracic aortic aneurysm disease. I think it's fair to say that we have proved this concept, that all of the measures representing aortic function are independently associated with aneurysm expansion. We have demonstrated the role of aortic stiffness that may be even more relevant in women as compared to men, and that some measures of aortic function are even better than the current standard of care, which is the aneurysm size, in assessing future aneurysm growth. We have demonstrated that central blood pressure is more relevant than brachial blood pressure in assessing disease activity in TAA. We have demonstrated that we don't need to repeat the hemodynamic assessment year after year. And we have demonstrated that in the absence of technology to measure aortic stiffness, we can estimate it and still have good information from that estimated stiffness measure. So where do we go from here? We are now funded by CIHR for the PREDICT TAA study, which is a 5-year multi-center study that is going to focus on 2 key measures of aortic hemodynamics, the carotid femoral pulse wave velocity and the central pulse pressure, and is going to recruit throughout all of these different sites. And we hope at the end of 5 years to derive and validate a TAA growth prediction model. So that's step 1. And as we develop now a larger sample size with longer follow-up, we hope to be able to then assess the role of these hemodynamic measures on hard aortic outcomes, such as aortic syndromes and death. And then at that time, we should hopefully be ready for clinical implementation strategies to make us smarter as clinicians and to improve the care of our patients. So with that, I'll end here. And I'd like to thank not only the funding agencies, but also this amazing team of technicians, research associates, collaborators, trainees, all of you that have been involved in our research over the years. I'd like to thank you very much. This is only possible because of you. And I'll be happy to take any questions at this time. Thank you.
Great, thanks, Taishi. I think, just as advertised, so super clear and very exciting progress from the point of view, of going from kind of a 2-dimensional measurement, to something that actually involves the pathophysiology in the disease process, which I think is really very important. There are some questions, I got tons of questions and suggestions, but there are questions coming through. Maybe I'll start out with Ali Amadi, who, really thank you for the great talk. Excuse me. Sorry. I have 2 questions. One is that does the existence of atherosclerotic plaques, in the thoracic aorta have any influence on the growth rate?
Yeah, I don't think anybody knows the answer to that. And differently than the abdominal aortic aneurysm, atherosclerosis is actually less of an issue in the thoracic aorta. If you look at an abdominal aortic aneurysm, almost invariably, you're going to find it riddled with atheromatous plaque. In the thoracic aorta, sometimes you do, and many times you don't. So I don't see atherosclerosis as being as key in the pathogenesis and disease activity of a thoracic aneurysm as compared to an abdominal aneurysm. And I think I see the follow-up question here,
yes, yeah.
Which is does the abdominal aortic aneurysm have similar pathologies and risk factors as TAA? And the answer is yes and no. Yes, because age is a risk factor for both pathologies. But in the abdominal aorta, smoking is by far, in addition to genetics play a role on both sides, but smoking is by far the greatest risk factor for AAA. When smoking does not play as strong of a role in TAA. In TAA is actually hypertension. So it's the same vessel, but depending on what part is affected, it's a very different patient that we get to see. So obviously we have our genetic aortopathies of these patients that pop up aneurysms everywhere, and that's a separate story. But for the average AAA and an average TAA patient, your average TAA patient is going to be an older hypertensive individual, and your average AAA patient is going to be an older smoker or former smoker individual.
Yeah, so I think the point there is really actually the flow dynamics are very different, right? You know, when you're actually the thoracic aorta, you know, it's like driving across a curve, right? Mm-hmm. And so it's really actually a much higher speed of flow, whereas in in abdominal aorta, it's much slower. You get a lot more vortex. Yeah, so absolutely. So it's the pressure, you know, and those dynamics are critical for thoracic, and you know, the more atherosclerotic risk in the lower aorta. And so great, thanks for that question. And so Emily also says great talk, and very proud to be part of the team. And so thanks, Emily, for that comment. And so the question is about antihypertensive therapy. You know, so what does that do to aortic stiffness?
Yeah, that's the elephant in the room, because I just talked today about aortic stiffness in thoracic aortic aneurysm, but the reality is that aortic stiffness has been shown to be implicated in a number of pathologies, you know, from HFpEF to valvular disease to myocardial infarction to stroke to cognitive dysfunction, all of these things. However, there's no easy way to reverse aortic stiffness yet. We know that we're much better off prevent or decelerate aortic stiffness. We can be much more successful in preventing or decelerating than we can be at reversing. So for everyone interested in preserving your arterial age as long as possible, preventing arterial stiffness, if you engage in the usual life, you know, healthy lifestyle measures that we all talk about, but especially aerobic habitual exercise, that is like the fountain of youth for aortic aging. That's a nice way to prevent. Now, once aortic stiffness has installed itself, as I made an elastic comparison here, there's not much I can do to this elastic once it's broken. So the antihypertensives that we use in general, all of the classes, they have been designed to lower systemic vascular resistance and thereby lower mean arterial pressure. They have much lower effect on actual aortic stiffness. And as a separate note, this is why you can treat a young patient with hypertension very easily with these drugs, but when you get your 80-year-old with isolated systolic hypertension and you just put drug after drug after drug, and all you do is lower their mean pressure by lowering the systemic vascular resistance, but you don't affect their underlying pathology, which is the arterial stiffness. So there's still not great studies out there. I have been personally watching and waiting for results of like Entresto and the sacubitril inhibitors, because there have been greater changes in pulse pressure in older patients with systolic hypertension that have been demonstrated with those drugs, but that's still not ready for clinical implementation. So lesson here is prevent this from happening to you, because as of today, once it happens, we don't have really great ways of reversing it.
Yeah, so exercise and, you know, secret Taisha is also vegetarian. Yeah, so maybe last question. Oh, I have great suggestions on the choice of antihypertensive medications, but we'll talk that offline. Last question, maybe because of time. Rizwan, an interesting question. What does a pregnancy do in terms of aortic stiffness? Of course, there's a certain change during pregnancy, right? So how about the aortic stiffness in women in terms of the number of children they have?
Love this question. That's another project that we have that Emily Pecan is going to be jumping in her seat, I think, because she's working on this. So great question. So in a normal pregnancy, aortic stiffness goes down. So as part of the hemodynamic changes of pregnancy, pregnant women make an abundant amount of this hormone called relaxin, which is actually made to relax your joints, your pelvic joints, so you can accommodate this growing baby and actually birth it later. But relaxin also relaxes the blood vessels, and it does improve arterial hemodynamics. So in a normal pregnancy, arterial stiffness actually goes down a little bit. And as a side note, when I was pregnant myself, I monitored my own arterial stiffness to make sure it was going according to plan, and it was. But what happens though is interesting as a parallel is that there have been some studies, especially from our colleagues in McGill, that have shown that some women do not have this expected decline in arterial stiffness with pregnancy, and rather their arterial stiffness increases with pregnancy. And interestingly, these are the women that very often go on to develop preeclampsia. So there is definitely a role for assessing arterial stiffness in pregnancy and beyond. And I think a second portion of your question is follow-on for this. Is there a difference with aortic stiffness in women depending on the number of children they have? That's a tough question because the parity will almost always be collinear with age, right? So typically, the more children you've had, the older you are, and in general, and age is the number one determinant of arterial stiffness. So to separate parity from age is a little bit difficult. I will just tell you that in our own database here so far, in our EVA study, early vascular aging study, we personally have not found an independent association of parity with arterial stiffness, both in patients with preeclampsia or in controls.
Yeah, so just wrapping up, Hassan Mir thought it was actually a great model for building a great research career. Dr. Masana, thanks for the great talk on a fascinating topic. And David Burney also congratulates you as well. So, so that's great. And yeah, so I'll take it offline because I just figured out what the biomarkers you need to actually predict this, and what the therapy you actually need to actually inhibit this, and in fact, how you may be able to actually predict this with even greater accuracy. Yeah. So anyway, so that's for a coffee with Taish. Yes. So thank you so much for this fantastic talk. So really clear and really exciting, lots of progress, important contribution, really just not only come as advertised, but in fact exceeding expectations. So thank you so much, Taish. Keep up the wonderful work. And thanks everybody for joining us. There'll be no rounds for next week because of Victoria Day, but after that, Lynn McGinney will give us an update on his research. So take good care, everybody. Thanks again, Taish.
Bye-bye, thanks so much.